Just to build on what Sam mentioned on the evidence in other areas than orthopedics, we know that NGS has been around for over a decade now, helping us with diagnosing and detecting infection. One of the early works that grabbed a lot of attention was this study that with the help of NGS, they could identify neuroleptospirosis in a 14-year-old kid that essentially saved his life and grabbed a lot of attention with New York Times and everything, and was really a shifting point that allowed us to focus on NGS for helping in detection of microorganisms. The first study that was done in orthopedics was a case study that was done with Dr. Parvizi's group in a patient that was 3 years post-operative and was failed, but culture was failing to detect infection. And NGS actually detected strep Canis. And at that point, it was an odd organism for us because it's not that common to see strep Canis in a periprosthetic joint infection. And as you know, this is a bacteria that grows in the oral cavity of cats and dogs. And after getting more detailed story of the patient, we realized that he recently had a puppy with a scratch on his limb that was licked by it. So the antibiotics were tailored towards this, and the patient was revised and has been successful ever since and hasn't failed. So this is a prime example of a culture negative PJI that the signal was picked by NGS. This led to another study that was done again by Dr. Parvizi's group looking at the sensitivity and the specificity of NGS versus culture. And the results showed that NGS is sensitive of 89.3% compared to 60.7%, which to me, the more important point is that among the culture negative cases that were 11 in this cohort, NGS could detect infection in 9 of those. That's 80% of our culture negative cases. And this is something that I really like about NGS because I feel like with the ones that have positive culture and have full-blown positive criteria for infection, we're not really worried. We know what is going on. But these culture negatives are the ones that we are curious about. And I think NGS is a big saver in this area. What I try to do in this quick talk is just tapping on different bodies of evidence that is available with different utilities of NGS. And I'm going over these studies with you quickly. So we talked about NGS versus culture with intraoperative sampling. Now the question would be, can NGS detect signal with synovial fluid aspiration? Because as we discussed earlier, with biofilm formation, synovial fluid aspiration has a lower yield. And the answer is yes. There are studies prospectively that shows NGS not only can detect signal with synovial fluid aspiration, but the sensitivity is better than culture. The other question that comes up is whether or not NGS can be utilized in other joints. And the answer to that question is also yes. Dr. Namdari, who's a good friend of mine, did this study comparing culture to next generation sequencing in shoulder. And they found that one of the advantages of NGS is that with multibacterial infections, NGS can actually detect the signal for most of them, because as you know, one of the limitations of culture is that it mostly shows the most aggressive or the most common organism, and the rest of them are not really reported. And NGS can again help with this. And there is this hypothesis that with some of these recurrent infections, they're not really recurrent, but that the infection has never been eradicated, and we took care of one of the bugs, and the rest have been like in this opportunistic mode, and when the antibiotics went away, they can grow and cause failure. And does it work with C. acnes? I think that's a big question that shoulder people have, and this one is a very interesting study. They had 40 swabs that they opened up in the OR, and they closed it down, put it in a container, and sent it. So essentially, just getting samples from the OR air, and C. acnes was identified in 15% of the cultures, and they also had coag negative staph in 7% of the cultures. So this just shows you, number one, whether these are contaminations in the OR air or problems we have with sampling of culture and incubation. But NGS detect only 2 positive cases. So this is just some food for thought, because I know that there's sometimes concerns about false positives with NGS, that with new technologies and machine learning, these are all set to rest. Now, the other concern is low volume. As you know, aspirations are not always easy. Oftentimes you have very low yield of synovial fluid, and we would kind of juggle to say, okay, should we send it for synovial fluid analysis? Should we send it for culture? This is a very interesting study coming out of China that shows even 1 milliliter of synovial fluid is enough for synovial fluid next generation sequencing analysis. Again, the companies usually would ask you to send as much sample as possible, but just the point to keep in mind that with low volume, NGS still works. Now the question comes for reproducibility. Is it something that other people had same results with? And the answer is yes. There's this study that looked at metagenomic next generation sequencing that showed higher sensitivity, specificity, positive predictive value, negative predictive value compared to culture, and other studies showing the diagnostic value of next generation sequencing having the same results. And the final question that I think is one of the most important questions, is it worth it? And this is a very interesting study again that looked at the cost effectiveness of NGS. And the results were kind of surprising to me, because culture is not deemed to be cost effective compared to NGS. And this goes back to the point that you should not compare culture to NGS head to head, but keep in mind that we oftentimes send multiple samples. So the incremental cost effectiveness ratio was more than 420,000 per quality. Also, the one-way sensitivity analysis found that NGS is more cost-effective when the pretest probability is high for PJI. So that's something to keep in mind. And lastly, as mentioned in my previous talk, that I think time is of an essence with PJI, I think NGS has the potential role to guide our management for these patients. If I have a suspected patient with PJI, I need to know the results yesterday. I don't want to wait 2 weeks, 3 weeks for culture to come back, because I want to be within that golden period to be able to do it there and not to go through a 2-stage exchange, which has high morbidity and can even increase mortality rate. We published a paper a few years ago that shows the mortality rate of revision due to PJI is 5 times higher than aseptic revision. So something to keep in mind. Thank you.